Welcome to She's Well. Today we are diving deep into the topic that affects thousands of families worldwide, but often goes unnoticed, CMV, short of Cytomegalovirus. It's a virus most people don't even realize they have had, but it can pose significant risk during pregnancy. Joining me today is Dr. Afshin Pourmirza, a German board-certified obstetrician and gynecologist, and a leading expert in fetal medicine with over 2 decades of experience, specializing in high-risk pregnancies, advanced prenatal diagnosis, and fetal infection. He has performed over 10,000 invasive procedures and thousands of specialized ultrasound as a founder of UAE's first dedicated fetal medicine clinic, including the Feto-Maternal and Genetics Center in Dubai, Healthcare City. Dr. Pourmirza has been instrumental in advancing the field. A passionate researcher, educator, international speaker, he continues to shape up the future of fetal medicine through groundbreaking innovations and medical excellence. Welcome, Dr. Afshin.
Dr. Bushra, thank you very much.
Yeah. So do you want to say something about your introduction? I tried, and I think it's not enough.
No, that was very comprehensive. Thank you very much.
Yeah. So when we were discussing other day and we talk about the cytomegalovirus, and I was telling you that I just posted this very small video on cytomegalovirus, and it has so many likes and share, and it wasn't having enough information. It was just talking about IgG and IgM, and I was thinking that so many people want to know about it. So let's do cytomegalovirus or CMV today. So tell us, what is CMV?
So this is a virus, and you have to be really a virologist to go on all the details.
Yeah.
I think for the audience, it's important to know that belongs to the family of the herpes viruses.
Exactly.
That is important to know. And then whoever had a herpes in life, herpes
They're immune
labialis,
forever.
genitalis, once you have it forever, because they are intracytoplasmatic, so they go in the cells. You never get rid of it. And like normal herpes, as you remember, every time we have an immune deficiency, we don't feel well,
attacks back.
it pops up.
Yeah, exactly.
So gladly by CMV, it is less frequent. The patient or the individuals need to be really immune suppressed in order to happen. Whereas a sore herpes happens more frequently.
Right.
Compared to that one. Gladly.
Exactly.
The prevalence in the population is very high. There are some studies saying that until the age of 80, almost 90% of the population had CMV at some point. And it was interesting to see that basically up to the age of 6, already 60% had a CMV infection.
Already.
Which brings you directly to the level of infection, which makes clear that at the time we are in the primary school and in kindergarten, the hygienic aspects are not really prepared, or at least the mindset is not there for small children. They play around.
Yeah.
So basically, that gives us brings us directly to the position that we know that ultimately the hygienic aspect is the only prevention we have. But how do you want to try to convey that message to small children in kindergarten? Not
exactly.
Possible. And the kindergarten children are the one basically channeling the virus into the family.
Yeah.
So a pregnant mother having a young child, and what do you do with the child coming back from kindergarten?
Right.
You play around, you kiss the baby.
Exactly.
Bingo.
So being pregnant, people should, or pregnant women should avoid kissing small kids. I think that could be one of the prevention measures.
That is one of the, this is one of the recommendations, but actually try to explain to a mother not to kiss the baby.
Exactly.
And try to explain to the baby,
pregnancy.
the mama is kissing you because you just came from kindergarten.
Yeah.
You might have CMV, so
yeah,
it's no good.
Or maybe kissing on the lips can be avoided because it can be We will talk about. So let's talk about how it could be transmitted. Can it be just transmitted through just simple shaking hands
No,
or
it is transmitted through body fluid.
body fluids? Yeah.
So body fluid, urine, blood, saliva,
Right.
most likely saliva,
Yeah.
right? Because in order to come to exchange of the blood is very unlikely. Correct? So
Yeah.
it's not very unlikely.
Right.
Exchange of urine also very unlikely
Unlikely.
by
Yeah.
normal hygienic conditions.
Right. Right.
So remains saliva everywhere, basically.
Yeah.
So maybe
So it's a hand
maybe you eat
washing.
a cookie
Cookies.
and then give a cookie to the baby, or the baby eats a
Yeah.
cookie,
Yeah.
and you say, okay,
Sharing foods.
you don't want to throw away the rest of the cake or cookie.
Exactly. Or sharing utensils, maybe
Yeah.
eating from the same plate also.
Yeah.
So that's a thing. So this could be one of the measure that once people are pregnant, they should avoid kissing kids, small
A bit higher
kids.
hygienic.
Yeah, standard hygiene and simple handshaking doesn't transmit the infection, but saliva, so kissing kids, sharing food,
But the same
sharing
handshake applies to a lot of diseases like toxoplasmosis and
diseases.
so.
Yeah,
That as long as you play with the cat, as nothing happens. Cytomegalovirus is the same. Shake hand, nothing happens. As
Yeah.
long as you follow hygienic.
if you're washing
orders.
hand before and after.
Yeah.
Yeah, that's amazing. There was one question like how many people, so when you said it's really, really common in the world, so probably most of the people are already have infection and they're safe because of their immunity, but still it can be some of the people who could be not having the infection already, so they will be the one who will be at risk. So by this we are saying that in general public it's not a concern, or is it?
Actually not. See, the point is the onset of the CMV is undetectable, more or less.
More undetectable.
Just sniffing in the nose, blocked
Yeah.
nose, not even a high fever, maybe just a bit temperature, a bit above the level for a short while.
Maybe we're considering some smaller
Yeah,
upper
it could happen to
RTI.
all of us even without knowing.
Exactly. We will not know.
So that is the issue. We don't have any skin lesions referring to it. We don't have any particular things referring to it, unless it's exacerbated.
So
But the
no
exacerbation
symptoms.
has totally different pathogenesis, because then somebody's immune suppressed and all the things comes together.
Exactly. That's a
But the
subset of the
primary
population.
CMV infection
Yeah.
is inapparent.
No.
And
So you being fetal medicine, so let's talk about why we are discussing CMV, because of the implication during pregnancy. So during pregnancy, it could be really important. So do you think, like when we talk about the CMV and CMV risk, so are these the different strains or types of the CMV which can pose different risk? Can they be having different varying risks?
so we have one human virus, basically. I think as far as I am aware, there are 11 different ones.
Yeah.
But the other ones are not affecting us as a humans. There's only
Right.
one which is widely examined.
Right, right.
So that is the one which most of the studies are available, most of the treatment methods are available. So the question is only,
It's probably the risk by primary and secondary.
infection.
So that is, rather than strains, it's the
the primary
Then-
infection is the one. And if somebody is not lucky in getting the primary infection in the pregnancy,
yeah, exactly.
you know how it is always in life.
Yeah.
If
Oh my gosh.
how many patients did you have? They have some kind of
I was telling you one event, one family, they just got positive for IgM and it was feeling like somebody burned down the roof from their head.
No, but I had also patient. Usually rubella. Let's say
Yeah,
rubella.
exactly.
Rubella you get in kindergarten.
Yeah,
it's very
exactly.
common. It's impossible.
And also MMR
Yeah,
vaccine.
it's impossible to get to the age of 5, 6, 7 before getting
Exactly.
rubella.
Yeah.
I had patients suddenly they're pregnant, and bingo, within the pregnancy they had contact with the rubella, and they get rubella in the pregnancy.
Yeah.
Or measles, the same story.
Exactly.
And how unlikely is that?
Yeah.
But that's life.
Yeah.
Things happens.
Things do
So,
happen.
and that's why hygienic aspect has to, the standard has to be high, provision need to be in place. It is difficult, and I think it is not possible if you have a toddler going to school or to kindergarten. You cannot ask the mother not to kiss the baby. You cannot
Exactly.
tell the baby don't jump in the
Exactly.
hug the mama and kiss the mama. It's not possible.
Exactly.
It is an integral.
Or maybe the way of kissing, not kissing lips, being sides,
of course,
you know.
But saliva is everywhere. Babies,
Exactly.
foot in mouth, in the
Especially
face, cheeks.
the toddler. Yeah, exactly.
So it is what it is. I think there is a certain risk. I would say the risk is not that big. We don't want to scare the people. The risk is small because most of the people are already infected. The primary infection was there.
Yeah.
So it is no, we don't want, and it's very simple. There's a simple blood test to check the IgM, IgG.
Yeah.
Even if somebody's scared, we have people that are a bit more sensitive, which is okay.
It's hard to
And
counsel
before getting
them.
pregnant, they can do all the checks.
Yeah.
They all do all the checks,
Yeah.
identify your risks involved,
Yeah.
and then go on with the pregnancy.
So let's go to this thing now, because we already established that it's not a problem to the general population. The only people who are at risk are either immunocompromised or the pregnant ladies. So when the pregnant ladies come, we do the testing. So we do IgM or IgG testing. Do you educate this universal screening? Because some of the countries actually, they do not have the part of their screening program. Even in Dubai, some of the insurance, they don't approve that.
Yeah. This is a dilemma actually, because we as doctors, we know what is good for the patient.
Exactly.
But that is sometimes in contrary to what the insurance approves.
Exactly.
So if as I mentioned, I am working here since 22 years.
Yeah.
So you can imagine at that time there was no insurance.
Oh, yeah.
Correct?
Yeah.
So patient came, you told them what is important for them and which tests are required.
Right.
And they did it. Who could not financially manage that? Of course they could not.
Yeah.
But who understood the importance of that test, they did it.
Yeah.
Right. But now the issue is with the onset of the insurance. And we see it everywhere, not only in Dubai, you can see it in Europe, you can see it in Canada, in Australia, everywhere.
Yeah.
Once the insurance is in place, people are relying on the insurance to pay everything.
Yeah.
Once this mindset is changed,
Yeah.
because then they will tell you, oh, doctor, if it is that important, why is my insurance not covering it?
Yeah. This is very common.
So to me, as a patient, my logic is that is not important.
Yeah.
This is
Exactly.
So I know the time from a different time compared to now, which really we have this kind of discussions.
Right.
So at the end, our job is the education,
yeah.
is the integral part of our job, to give the knowledge.
Exactly.
That we tell them what is good, what is bad, what they need to do.
Exactly.
The ultimate decision is the patient's. And this is exactly what I do in my documentation.
Right.
Basically, I document patient, the client. They don't need to justify. They have the right to say yes or no. And usually what happens most of the time, I give the instruction, I give the education. And since I have a referral center, very, very often, I send the patient back to their own doctor because they might feel more comfortable.
Exactly.
Doing the blood test there.
Right.
Right. So that is a standard thing. And that's why it is a real dilemma with insurance. From one side, the people are relying on it, covering a lot of expense.
Exactly.
Having an insurance, health insurance is actually a human right.
Yeah.
So that is a fantastic job which is done here.
Yeah.
Within that short time span, we have the insurance implemented, which, let's say, Europe took them 200 years to implement.
Right.
So that we have to really clarify it clearly.
So, but it's better to do it.
But it understands also from the patient side that you cannot take the insurance as a vehicle and put everything on the head of the insurance and say, okay, there's also a self-responsibility and self-management of this.
So it's better to determine your risk, especially in the first trimester, at least doing CMV IgG.
Just hypothetically, there is a woman, she's very anxious, she wants to get pregnant.
Yeah.
She's one of those, she wants to make sure everything is okay.
CMV IgG.
So if she comes to you and she tells you, I'm not pregnant, I'm trying to rule out all the possible problems in the pregnancy. I would like to have all the viruses, measles, rubella, CMV, toxo. I want to check them all.
Yeah.
You have to ask for pre-approval by the insurance.
Yeah. Actually, I do rubella
I know,
testing.
but she's not pregnant.
Yeah, I do it before because I can give vaccination.
Is the insurance paying for it?
No, it's cash, self-paying,
Exactly. So this is where the problem starts.
Yeah.
It means if you want to be proactive,
But actually for rubella, you can do something. But for CMV, you can't do something before.
No, but if somebody is anxious,
Yeah.
they have the right to know.
Exactly.
Correct?
Yeah.
They say, okay, I would like to know. But the problem is it goes to the limit of the finance again.
Exactly.
Who is paying for what, right?
Exactly.
So there's a prolonged discussion.
Yeah.
But generally speaking, what I'm trying to express is that everybody is responsible for their own life, for their own
Exactly.
health. The insurance is
But
supportive.
education also they deserve, and then
Yeah.
they have to do the informed choices.
but
Yeah.
that's why the
But
better.
you do recommend CMV testing, even people who are planning pregnancy, to know what
You see,
precautions.
we don't want to scare them.
Yeah.
If somebody is overly anxious, they will read, they come for education, they will come for consultation, they will get a list what we think they should do.
Exactly.
Most of the reality is different. The reality is people are getting pregnant and then they are anxious and they are coming to the clinic.
Exactly.
Right?
Yeah.
So in those cases, I recommend for all the patients,
They should
the
do it
torch is standard
universally.
in my clinic for all the
Amazing.
patients.
Yeah.
And there are hospitals that are not doing it, there are clinics that are not doing it, all of them referring to the insurance.
Exactly.
Insurance not covering.
Yeah.
But then ultimately, I mean, there are 500-600 dirham.
Yeah, exactly. So message is that it should be recommended. People should do it if they want to take some, they want to be proactive, they want to know their risk status, because there is still some measures they can do to reduce that risk. So then we were talking that the primary infection, which is more important. So I found my patients, say suppose if they are IgG positive, okay, fine, they are safe most of the time. But if they are IgG negative, then is the risk start that IgM we have to check, or maybe when they get some sniffles, then they should check the IgM. Normally, actually, I do the whole panel, and a lot of insurance is approving the whole panel, the old torch profile IgG IgM, and I tell them that you're at risk or not. So let's talk about the timing of infection, which is really important. So then, yeah, would you want to? Yeah.
So timing of infection, generally speaking, the earlier, the higher the damage, the problem.
Yeah.
But again, the issue is the detection of the infection.
Yeah.
If there is no symptoms or hardly any symptoms,
How would you detect? Yeah.
I mean, you cannot go around to a doctor if you're negative IgG.
Exactly.
And every other week say, oh, I am scared because I had a blocked nose yesterday getting out of my car.
Exactly.
That's not possible.
There's so many infections already to cause
So then at
sniffles.
some point there is a balancing act between what is possible, suitable, what should be applied. So,
Exactly.
and that's why it's very important in the pregnancy to be calm. And then keep in mind, not every infection, this is very, very important. Not every infection is ending by an infectious baby, right?
Yeah.
The placenta is a barrier and it's holding back a lot of viruses and infections.
Exactly.
But sometimes we have a transmission and then we see a vertical transmission and then we see the baby is infected. Gladly, this is not that frequent. This is it's good so.
Yeah.
But that's why people should be not overly anxious or I
Exactly.
got a blocked nose. That could
Yeah,
be-
exactly.
Right.
So
It's manageable, I would say.
Exactly. So one population who is IgG positive, they can be reassured that there's a very less chance of having infection. IgM, if IgG negative, yes, any nasal symptoms, you could be at risk of the thing, but it's not isolated because we'll be doing a scan also, anomaly scan. So if any damage is happening, that will also
So
be vivid.
the problem is actually in ultrasound, those findings associated with infections, generally speaking, cytomegalovirus is one of them. They are apparent in ultrasound to us after 5 to 6 weeks earliest,
Yeah,
after the initial infection.
exactly.
So it is not the way that there's infection and 1 or 2 weeks later we can see the problem.
Yeah,
That is the issue. So now I think IgM, IgG is a very good tool. It's very stable tool,
exactly.
widely validated to basically to pinpoint who is at a higher risk, who is at a lower risk,
Exactly.
who has the immunity, who doesn't have the immunity,
Yeah,
and deal accordingly.
yeah,
We have cases which the IgM is positive,
yeah,
IgG is also high positive.
yeah.
So
that's a
so-called
reactivation
equivocal.
or-
so-called equivocal, which is not really negative, which is also not really high positive. This is all, I would say, we have a lot of patients like that. And most of the time, because we are dealing with the infection, actually. So once I see the IgM, IgG result, it tells me instantly, roughly, when the infection was there.
You do avidity after that?
No.
Okay. So, but if high avidity...
No, the Avidity, the Avidity was invented in the 90s by Professor Enders in Stuttgart. It's a German professor, a lady.
Yeah.
She and her husband, both professors for virology, they have a lab in Stuttgart, and they were the one inventing it. So the Avidity, I have to tell you, maybe in the last 22 years in my clinic, I did it maybe 2 times.
Yeah.
And then if I do it, I send my sample to them.
Yeah.
It's more expensive because I had also experience here, and nothing against the lab, but the issue is they try to copy paste.
Yeah.
And then sometimes the results were not matching with the clinic.
Yeah.
And then I had to react to it. So that's why the Avidity is actually the last option.
Yeah.
It is too often used without real benefit. If you look at the IgG IgM, you can exactly predict roughly when was the infection.
Yeah.
I can tell you whether the infection was 5 years ago, 10 years ago, recently, based on the ratio between the IgM and IgG, but mainly the level of IgG.
Yeah.
Right? So if you have IgG, which is very high, of course, a recent infection. If you have IgG, let's say around 150, you have still the immunity, but it's an old infection. Right?
Okay.
Then you can say, oh, it must be a decade.
Okay.
Right? If you run around 300 to 400, it's okay. Maybe it was 5 years ago. So if you deal like us daily with infections, you look at IgM, IgG, and that's why there is hardly any invasive examination done, like the PCR on the amniocentesis, in amniotic fluid, to verify if the baby is infected or not.
Infected.
Right.
So our lab, what I see the report, either it is above 500, or if it is less, they put the number. So anything above 500, you will say it's an old infection, because then they don't put the value. They put value only.
I know, but if you have IgG, even 70, 80, you are covered.
It's an old one. But if it's above...
you are covered by immunity, right?
Immunity,
so,
yeah.
Right. So
And it's an old infection.
If you see only IgG alone, no IgM, then you are covered, you are relaxed.
But if it is above 500, then we should do the IgM. Because it could be recent.
I would suggest you should do the IgM initially, instantly.
Okay.
It doesn't make it more expensive. It's just
Yeah.
not much more expense in it. So I do in my clinic, patient comes, for my own patients too, IgM, IgG instantly.
Yeah, perfect.
This creating, in some cases, anxiety for no reason.
Yeah.
Just imagine I do only the IgG.
Right.
The IgG is questionable.
Right.
Then I have to go back to the same patient.
Right.
It's okay, let me to do the IgM to see what the story is here.
Right.
Then in that few days, before getting the result, this patient is boiling.
Yeah, exactly.
Why? Take a blood
But
from day one.
say suppose if someone IgM negative and IgG above 500, it still means that like it wasn't very old. It's not old immunity. It
I
happened
know, but
maybe.
the IgG is prevailing around 12 weeks in blood, right?
Yeah.
So if there's no IgM, then you know exactly the last 12 weeks, there was no infection.
No infection.
Otherwise, you would see the IgM.
Yeah.
So if you look at the profile of the infection, the IgM, I compare it always an analogy for my people, might be not a nice analogy, looking what happens around us in Ukraine, for example. I call it somebody's invading your country. You take everybody from the street, give them a gun and say, go and fight, defend your country.
Yeah.
These are untrained soldiers.
Yeah.
They have a lifespan of 12 weeks.
Yeah.
Then they die on the field.
Yeah.
But that gives you time to train your National Guard, which is IgG.
Oh, wow.
And that goes
I
gradually.
love your analogy.
That goes gradually high, right? At the beginning, you have no IgG,
Mm-hmm.
and after 5-6 weeks kicks in, the IgG shoots up,
Exactly.
and then the IgG takes over, and you don't need the IgM because they're dying anyway because not well trained. Now you have a National Guard who's lasting forever,
Yeah.
and they're forever there, and they're defending every time the same enemy related to this IgG comes in. They're defending your body.
Right.
Correct.
Amazing.
So if you understand that game, how it plays out.
But if you saw this patient with the high IgG and very high IgG and negative IgM in second trimester. How would you interpret that? It is could have still got the infection.
I
in
would
the
say,
first.
see, you can have even the Avidity test gives you a time frame which is roughly accurate for 3 months.
Yeah.
The 3 months you can read also in the IgM. You are not really needing. You don't need the Avidity test,
Yeah.
right? Because if it's 4, 5, 6 months, it becomes very vague.
Yeah.
It's a mathematical algorithms, basically,
Yeah.
right? It's become very vague. So from one side, waiting for a proper IV test to come from somewhere,
Yeah.
a week, patient's anxious. And I would say 98, 99% of the cases are solved instantly.
Instantly.
I think the part which is causing a lot of confusion is not the negative IgM. It is the borderline IgM.
Yeah, it's very
That
common.
is scaring them.
Yeah, why?
So if you imagine I'm getting an infection, 3-4 days later the IgM kicks in, then you have a curve. The peak maybe around 5-6 weeks after the initial infection, and gradually is depleting, going down towards 0.
Yeah.
Around 4 to 5-6 weeks, really the IgG kicks in and shoots up.
Okay.
So if I have a borderline IgM, but no IgG, that gives me two information. Either it is the beginning of infection,
Yeah.
which no IgG is present in blood,
Yeah.
or it is a cross reaction.
Yeah.
It means it is
a false
because
positive.
we have this kind of reagent and material which are
Cross-reactivity.
reacting to antibodies.
Yeah.
Sometimes you have different antibodies,
Right.
which you don't know
Yeah.
which one it is,
Yeah.
but they have a cross reaction.
Yeah. So it's a false positive.
Exactly. So you have
Yeah.
a cross reaction,
Yeah.
which is usually my borderline. I know around 1.2. It depends which chart you're taking, or 12
Yeah.
or 14, right? So for
Right.
those cases, it's very simple.
Yeah.
After a week, the next IgM.
Repeat. Repeat
And
testing. Yeah.
if you see within the normal variation, plus minus something very small,
Right.
it's the same.
So we should always
But
repeat.
if it's a really fresh infection and you
Yeah.
had 1.2,
Yeah.
then there will be about 35, 40
Yeah,
after
exactly.
5-6 days.
Yeah.
That rules out all the AVI tests, trying to find out
Exactly.
this and this. And by the way,
But
you
it
get
is Avidities for when both are positive. IgG, IgM, both are
Yeah, a
positive.
lot of people do Avidity if they have borderline IgM, for example.
Okay.
They do it. This
Yeah.
is the most common case are using
Yeah.
it, right? So, but then if you have a borderline, then you say, okay, I want to see where in the chart I am, right?
Yeah.
So, because ultimately you could be also at the end of the 12 weeks that your
Yeah.
IgM is very low,
Yeah.
but that requires your IgG to be through the roof.
Yeah.
Because a fresh infection, you have a lot of
Exactly.
IgG in your blood.
Yeah.
Right?
There has
So
to be.
this is a very, very easy game. It's usually also what I'm teaching to my patients who are coming.
Exactly.
I draw it for them. I have a drawing board there, and they love it always. They will see the thing at the
Wow.
end. Looks like a Picasso drawing.
Amazing, amazing. It looks like you're having a lot of fun with these
Yeah, I mean,
numbers.
Gladly,
Yeah.
but the good news, we have a lot of
Yeah.
fun. But the issue is, of course, sometimes they come to us, which we become suspicious, not through the laboratory, through the findings in ultrasound.
In ultrasound. Yeah, that's
And as I mentioned to
concerning.
you, the first set of ultrasound problems are basically identified by minimum 5 to 6 weeks
Yeah.
in order to see the damages and some of the
So
stuff.
you will
comes
find
in.
IgG, IgM both positive in those scenarios. If just in case
No,
they
because what happens, because
Yeah.
see, CMV is a bit kind of neglected because its
Yeah.
prevalence is very high.
Yeah, exactly.
Correct? A lot of doctors don't even do it. So now, then the patient goes to an ultrasound and they find something.
Right.
They find a whitish intestine, or the head is a bit smaller, right? Or placenta, or some calcification in the kidney, in the brain, or in the liver, or something.
Exactly.
So they send them to us, right?
Right.
So usually they send them because of the abnormalities in ultrasound. Correct?
Right.
So once we see the patient, we see the abnormalities, so we don't know what is it.
Right.
So we have to identify to see A, what was causing it, B, what was the time of the infection.
Right. Right.
Correct? But obviously, this is gladly a very, very small minority.
Yeah.
The vast majority of the cases, The placenta is protecting the baby.
Nice.
The virus, the agent cannot go through it. And that's the function of the placenta.
I was just reading that 1 in 200 pregnancies get affected by that. And out of those 1 in 200, 1 in 5 will be infected. So if you take 1,000 pregnant women, it will be only one which will be actually affected in the babies to have the congenital problems.
So basically every 200, one baby is infected because it means the virus managed to go through placenta.
Exactly.
Correct.
So and out of them, one.
And then
if
you have five babies, one of them, which is 20%, is going to have some kind of problem with that infection.
So when we put it in the all pregnant, it will be 1 in 1,000 women. So
it's going to have a problem.
Yeah, exactly, right. With the problem. So now we talk about that IgG, IgM, what is the implication of that. And I told you that I had one video in the past and it was shared and liked and commented a lot. And I was surprised that people really want to know. So those are not the people who are problems in ultrasound. Those are the people who have IgG and IgM and they want to understand what's happening with that. Somebody IgG positive already been reassured in the beginning and then later on they got reactivation, like IgM was negative but later on or whatever. So let's talk about the people who were reassured in the beginning and then they got IgM positive later.
So
what are the risks?
To answer your question politically correct, it makes very difficult.
Oh yeah. Yeah.
Because see, at the end, we are dealing with lab analyzers.
Lab analysis.
Correct? Yeah. It's a machine. So you and me, we are users.
Yeah.
We take the blood, we send to lab.
Right.
You have a lab technician, which is also more or less a user, is because she is not the one or he is not the one analyzing the values.
Right.
Correct? She does the pre-analytic and gives the blood to the machine.
Yeah, exactly.
The machine is running with reagents.
Right.
Right. So now, and all the machines, they have kind of quality control, which they need to be done.
Right.
On the regular, like a preventive maintenance.
Right.
So they need to be done.
Right.
So, and all the machines, like all the machines, in our life, they are subject to error.
Right.
Right. So now, if somebody is reassured that you don't have a fresh infection, your IgG is high, and now IgG is high, and now by the second test, it tells now you have an IgM and reactivation story.
Right.
Reactivation happens actually, as we agreed from beginning of our discussion, based on immune suppression.
Ah, okay.
Correct?
So it doesn't happen in a
normal general population being pregnant. I do not remember a case which, they are immune suppressed or they have some other, because just very simple. Some people have a Sjögren syndrome. Some people have a rheumatoid arthritis. They take cortisone in order to reduce the flare.
Right.
Those are the prime suspect because the immune suppression is allowing the CMV to come back.
Right.
Right. So there are very limited cases. But most of the other cases, which the patient doesn't take any medication for immune suppression, those cases is better to double check.
Right.
That test result, that particular one.
Right.
The problem is for the double checking, you have to ask the patient to come in.
Yeah.
So you have to confront the patient with that false positive result or true positive. You don't know at that stage.
Yeah, exactly.
So she will go again through an ordeal until the test result is there.
Right.
So, and then what will be the other option? The other option is then you say, to lab, I do not believe you. I need another test.
Mm-hmm.
The patient is waiting. If she waits 4 days or 7 days, usually if they are waiting, they forget about it, right?
Right.
So you give her one answer at the end. But the problem is the obligation to inform the patient, the relationship to because if you delay that information as a doctor, you cannot.
Yeah.
Because you're liable.
Yeah, exactly.
Correct? So you have to give it. So basically, you have to put that poor patient in that situation.
Yeah.
In the time frame until you got the second or third result. to say, okay, sorry, there was something wrong with the machine, something wrong with the reagent, maybe. So many maybes, right? So we don't know.
Right.
So that is the situation that we are facing, basically. Right?
So one thing I just understood that even you get positive, you give a space to the fact that there could be quality control in the machines and it should be repeated preferably in some other machine. So people who are reassured in the beginning because IgG positive, stay reassured. And even if it is a true positive reactivation, the risk is not
very
that much. So they can stay reassured.
Correct.
Now we go to the deeper side. IgG negative and IgM got positive later or in the beginning. What those people have to do?
Real positive.
Really, IgG negative, IgM positive. We confirm from 2 labs. Now she's the one officially labeled as CMV positive.
Okay. So there are antiviral therapy.
Yeah. Do you do the PCR or anything?
See, the PCR.
In mom and then in baby.
So no, see, if you have an IgM
Okay.
high, IgM high,
IgG negative.
IgM, let's say 80, 90, 100. This
Right.
is very clear. This is an
Yeah.
infection.
Right.
If you have any doubt, you can repeat it. This is relatively quickly given.
Right.
It's widely available, right? So
Right.
now, if you want to double sure, then of course you can go and make a blood test of the mother and look for the virus
PCR.
load, PCR in the blood.
Right.
Right.
Then.
Okay. You can take also, some, I don't know, lavage from lungs or
Yeah.
saliva, whatever it is to
Right,
make sure that
right.
the PCR load is there.
Yeah.
But this still doesn't tell you if the baby is infected,
Exactly.
right? So as we now agreed, not every infection goes through the placenta, so the transmission is suppressed.
That's
thankfully.
1,001, even with the IgM positive.
No, one in 1,000 was the baby with a problem,
Yeah.
right?
Yeah.
We agreed there are 5 babies in 1,000 who are getting infected,
Exactly.
right? And then one out of 5 is going to have a problem.
Yeah. Exactly.
But the infection is 5,
Yeah.
correct? So that 5 you have to find.
Right.
So how do you find them? Basically, either you see those changes in ultrasound, which is happening after 5-6 weeks.
Exactly.
Which is,
After 5 weeks, every
See, it's
2
usually
weekly
too
you
late.
do ultrasound?
No,
Serial?
see, usually what happens is a site finding, right?
Yeah.
Because there's hardly anyone having a CMV infection, monitoring, and say, okay, now in 5-6 weeks I have to go to doctor for fetal medicine to check the ultrasound. That's not happening. The reality is they're infected because it's an inapparent infection,
Yeah.
correct? So that's just site finding in ultrasound. This is one thing. The other thing is you can go there. There's a proven a coincidental finding of the IgM because the doctor did the torch, or maybe somebody else was infected, did the torch, informed them, listen, I have a CMV, check yourself, you are pregnant. Whatever.
Right.
So for those cases, we have to make amniocentesis.
Yes.
Amniocentesis basically means using a needle protruding through the amniotic membrane,
To the abdomen to inside.
aspirating the amniotic fluid,
Right.
which is baby's pee ultimately.
Yeah.
Right.
And that also
And-
baby starts making at 21 weeks. So you can't do it before.
They say 21 weeks, which is a bit. We have to see it a bit in a modular form because
Yeah.
depends. If somebody's infected by 19 weeks,
Okay.
and I do by 21 weeks amniocentesis,
Yeah.
very, very likely I do not find the virus load.
5 weeks from the infection and
So
after
minimum,
21
because you need a viral shedding.
Exactly.
So the baby is peeing. How did
Yeah.
the baby get? We have to always imagine how did the baby get the infection in the first place.
Yeah.
So the virus load was in maternal bloodstream, could manage to go through the placenta. It goes to the bloodstream of the baby,
Yeah.
correct? Circulating in baby's body,
Yeah.
going, for example, into the kidneys,
Right.
and the baby is producing urine, which is the
Yeah.
amniotic fluid,
Yeah.
and is peeing these particles of the virus out of the body.
Yeah.
So
5
and,
weeks.
and then the baby is drinking it again, right? So then you
Reinfecting.
need a minimum time to increase the virus shedding in the amniotic fluid
Yeah.
to be able to see that,
Yeah, exactly.
right? So that's why it's very important when to do it.
Timing.
So, but
Perfect.
then again, there are no studies showing clearly if you do it after 2 weeks, you have, I don't know, 30% false negative rate or so. Right?
But especially you're giving a risk of amniocentesis, so it's better the timing should be
the risk
correct.
of amniocentesis, I think we have to clarify to know what we're talking about.
Yeah.
If we have the news data showing very clearly, amniocentesis, the risk for amniocentesis is basically 0.12%.
Okay.
Means if you have 1,000 amniocentesis,
Yeah.
roughly one pregnancy will be miscarried.
Loss. Yeah.
Right?
It's
So it's
less.
a relatively small risk
Yeah.
considering all the other things.
Right.
Still, it needs to be justified.
Right.
The justification comes through the circumstances, through the lab, through the findings,
Right.
and ultimately the consent of the parents.
Right.
So, and in my generation, I'm a pre-NIPT generation, and the reason I had so many invasive testings was because at the time we were learning to become a fetal medicine doctor.
Right.
The place where I
So these days it is not encouraged much.
the days I was trained, I had around 15 to 20 amniocentesis a day or CVS a day,
Right.
not a week, a day.
Yeah.
So
that's too much.
then if you look at it, because whoever was above 35,
Yeah.
CVS amniocentesis.
Yeah.
There was nothing else on the table.
Exactly.
No NIPT.
Yeah.
So with the onset of NIPT, that went significantly low,
Nice.
right? With the NT, the first step came with the nuchal translucency.
Yeah.
First time as a screening.
Perfect.
That was down around 60-70%.
Yeah.
Because then you did the invasive testing for high-risk population,
Right.
not because of the age alone,
Okay.
right? That was the
Yeah.
first one. Then we had the NIPT, there was another kick. So we had another 90% reduction
Right.
from that very moment
Yeah.
because of the NIPT.
Right.
And
Amazing.
now we do it if the NIPT is high risk, could be false positive, for example.
Exactly.
So, and that is the same, that's why the risk for amniocentesis is very, very small
That's amazing.
compared to all the other procedures in medical field.
Yeah.
Still, you need a justification,
Right.
right?
So in this, like when you have IgM high, IgG negative, you do it?
IgM negative, no.
IgM positive, IgG negative, sorry.
Okay, if the
Vice
IgM
versa.
is high, in those cases, there's two ways. Either we wait and do the ultrasound,
Yeah.
considering the side effect of the antiviral therapy.
Right.
Right, so you have always to. This is always a game.
Yeah.
You have to make the mathematics. Not every.
So once
not
the
every
IgM
maternal infection.
positive-
Not every maternal infection is becoming a fetal infection.
Exactly.
You just said yourself 1 in
Exactly.
200,
Exactly.
which makes 0.5%. So 0.5% risk for the baby to be infected
Yeah.
if the mother is infected. From 200 infected mothers,
Yeah.
one baby will get infected.
1,000 out of 1,000, one will get.
No.
Mom,
No.
1,000
Again.
infected.
No. 1 out of 200 is
Uh-huh.
getting infected.
Yes.
But 1 out of 1,000 have problem with the infection.
This I'm saying, yeah.
The others can sort it out without
Exactly.
a problem. 1 out of 1,000,
Yeah.
so that is the odds you have on the table.
Exactly.
Right? So now compare the numbers. 1 out of 1,000 is going to have a problem like hearing loss, vision loss.
These are
whatever.
1,000 women who are IgM positive.
Yes.
And baby-
got a proven infection.
Yeah.
They have
proven
a proven
infection.
infection.
And,
And only one of those babies are having a problem. So,
5 are infected.
let's become mathematically.
Yeah.
Now, the risk for amniocentesis is 1 in 1,002.
Yeah.
Same risk.
Yeah.
So the risk for amniocentesis is 1%, right? One out of 1,000. The risk for the baby to be having a problem is also 1 in 1,000.
Yeah.
So both risks are the same, basically.
Almost same, yeah.
So for what you decide as the mother, as the parents, depends on your anxiety, upbringing, expectations, right?
Yeah.
Because mathematically, you cannot really defend amniocentesis.
Yeah.
Because it's the same risk like a baby. Yeah.
So
you can say,
don't
okay,
do it.
we do serial ultrasound. We do ultrasound in
Yeah.
4 or 5 weeks.
And we have a better scans these days also. So once
But see, the problem is always the same question. If you offer the serial monitoring to the patient, they will tell you, okay, if you see a finding, what can you do?
Yeah.
Then comes the next question.
Next question.
Right.
Yeah.
If we see the findings already, means there is something going on in the body of
Exactly.
the fetus.
Yeah.
So that is too late.
That's too late.
Because if you do the amnio at the beginning Again, you have to wait for a while to get enough virus shedding in the amniotic fluid to find the PCR.
It's too late, yeah.
Again, you're too late.
Exactly.
So that's why the antiviral therapy is not a priority in our field, because
So you guys don't give...
you cannot start
Therapy.
antiviral therapy without having a facts on table.
Yeah,
The facts on table coming later.
yeah.
Where the baby is infected or not infected, the 1 in 1,000 having some problems, 5 out of 1,000 are infected. Correct?
Yeah.
So, but all the evidence you want to bring on the table happens later.
Later. So we don't give IgM positive, no antivirals, no immunoglobulins, even though they are experimental. And they're experimental, of
I know,
course.
but experimental, nobody
Yeah.
want to be the
So
one.
it's just the observation, watch, that's it.
And gladly,
Monitoring.
the mother nature is sorting out a lot of problems.
Yeah,
That's
exactly.
gladly.
Exactly. So, a good thing, again, we will repeat, 1,000 women, out of 1,000, if women get IgM positive, out of them, like 5 kids could be infected, and those 5 will get, only one of them will be affected. Like infected and affected is just different. So all the IgM positive women, 1,000 women, among them, if they are IgM positive, IgG negative, they are at risk, their babies are at risk, but risk is not very big. 5 kids will be infected, and out of those 5, only one will be affected.
Having an issue. An issue.
Yeah, exactly.
Whatever the
could be any
issues.
issues. So if they're positive, findings are there.
In
We are
ultrasound-
in
ultrasound
UAE.
findings.
Yeah, ultrasound findings are there. We are in UAE.
So,
Then what happens, you know?
Dr.
like
Bushra,
the laws.
this is a very good question, very
Yeah.
fantastic question, which actually, this was from day one I have started here. It was
Yeah.
the same question from different packaging.
Right.
What do you do with Down syndrome via UAE? What do you do
Yeah.
with this? What do you do with that? Right? The same question,
Exactly.
different labels.
Exactly.
The preamble is for what we do.
Yeah.
We are clinicians.
Yeah.
We are not priests. We are not rabbi. We are not muftis.
Exactly.
Our job is to give the information for the patients,
Facts.
the facts on table. That is our information, right?
Yeah.
This is what we have to give.
Right.
What their decision is, we can give them the outlook. Nobody can tell them the baby is 100% has a problem. Nobody can give them 100% peace of mind.
Right.
There's a certain risk in life.
Yeah.
And this is what we do. And ultimately, it's their decision.
Yes.
So for a lot of things, if people say, I would like to have a termination done, just let's
They
name
have to
it.
fly.
No, termination is done here in this country only under conditions which are not viable with life. And those conditions are clearly identified in the orders and information from Ministry of Health.
Right.
It's all very clear.
So they are compatible with life with the abnormalities.
The same is applies to Down syndrome.
Exactly. So
Are
same rule.
compatible with life.
Yeah.
I cannot go there and say, okay, I don't want it. It's not possible.
Yeah.
Right? So at the end, again, we are no clergy. We are doing a medical job. We are clinician.
Yeah.
And our job is to make a diagnostic with the best skills we have, with the best knowledge we have. We have to translate that knowledge in a layman term the patient can understand. And at the end, the patient, the counseling part is the
Exactly.
difficult part.
Yeah.
To understand that is a risk I'm facing. This is the best case, is the worst case.
Right.
Then decide for themselves.
Yeah.
And we had
This is their decision, their
cases,
call.
We had cases not in this virus infection. We had other cases, physical malformations. They were not compatible with life, and those are allowed according to ministerial order
Yeah.
to be terminated here. But there is very stringent rule.
Yeah.
They are very clearly identified what is.
I want to ask one more question, the last one, that CMV also can cause something when baby is born completely normal and they can develop
Later.
later, like they can be normal hearing test, but later on they can be having the deafness.
Gladly, I am not a pediatrician.
Yeah.
So because
but
I
still
think
we have to
because
counsel
the
that.
pediatrician is a difficult job.
Yeah.
It's actually everything in one.
Yeah.
All what you know, is internal medicine, endocrinologist, all in one, right?
Yeah.
So I cannot tell you about the longitudinal aspect of the viral infection because I'm usually exposed to it prenatally.
Right.
And the first time after delivery, because that is then where we are confronted with things happening, right?
Dr. Afshin, I mean, it was so much information. It was informative even for the doctors, not just for patients. So we have a certain ritual because you will light this candle and that will symbolize all the information you brought to our space, the space of she's well. Hope she keep on staying well because of our information, and that's we all are struggling for. So you will light the candle. Okay. What happened to it?
I mean, we have fire.
Yeah.
See that.
Okay, just leave that one. Oh, it got it. I think my wig got smaller. So this will go with you as a souvenir. You will remember you brought information to our space.
Thank
the
you
She's
very
Well.
much. Thank you much. Very nice. Like Dr. Bushra, it is really great, the initiative to do all this efforts.
Information, yeah, exactly.
It's highly appreciated. I think there is a lot of patients out there that love all the information you are providing.
Actually, your information, not just for patient, it was for doctors
and,
also.
I will put my clinic in a nice place. I will be remembered for this nice conversation.
Thank you. It's an honor. Yeah.